Okay, let's dive straight into the clinical algorithm for hemostasis. No fluff today, just high-yield step 2 decision logic. We're going to build out your test day decision tree for the bleeding and thrombosis triage. This explainer will give you the exact mental anchors you need when you're staring down a complex USMLE vignette.
The very first branch point in your mental algorithm, it's the physical exam. If you see a patient with mucosal bleeding, epistaxis, petechia, or purpura, instantly think of a platelet disorder. You're probably going to see an abnormal platelet count or a prolonged bleeding time. On the flip side, if the clinical picture involves deep tissue bleeding, large hematomas or hemarthrosis, which is bleeding right into the joints, you're looking at a coagulation factor defect. That's when you expect a prolonged PT or PTT, depending on which cascade pathway is involved.
So what happens when you actually hit that prolonged PT or PTT? A one-to-one mixing study is your absolute ultimate diagnostic pivot point. The lab basically mixes the patient's plasma with normal plasma. If the prolonged PTT completely corrects to normal, boom! It means the normal plasma provided the missing coagulation factors. You've got a factor deficiency. But if it doesn't correct, well, something in the patient's blood is actively blocking the cascade. You're dealing with an inhibitor.
And that brings us to a classic board paradox. If the prolonged PTT does not correct with normal plasma, think of an inhibitor like the lupus anticoagulant. Now listen to this paradox. Despite the name anticoagulant, because it artificially prolongs PTT in the lab, in the patient's actual body, it causes catastrophic blood clots. It's a type of antiphospholipid antibody that actively binds up the phospholipids used in PTT tests, literally preventing them from inducing coagulation. Because it's an antibody occupying all those spaces, throwing more normal plasma at it just won't fix the lab artifact. Only adding excess phospholipids will overwhelm the antibody and normalize the test. Keep that pathophysiology in mind. It is absolutely massive for test day.
All right, Section 1, Thrombocytopenia and MAHA, the low platelet pathway.
First things first, watch out for diagnostic traps. See those massive purple clusters? That is pseudothrombocytopenia. It's literally an in vitro laboratory error. The patient doesn't actually have low platelets in their body. What happens is antibodies to EDTA, that's the anticoagulant used in the test tube, cause the platelets to clump together, and the machine reads it as a low platelet count. So if your patient has zero bleeding symptoms but isolated low platelets, look for this clumped smear. It'll save you from a totally unnecessary workup.
Now, when the thrombocytopenia is real, you've got to differentiate these three heavy hitters. First up, ITP. It's driven by platelet autoantibodies, often right after a viral infection. It features isolated thrombocytopenia. Remember, you only use platelet transfusions for life-threatening bleeding here. Otherwise, the move is glucocorticoids, IVIG, or anti-D. Next is TTP, which is highly life-threatening. It's caused by a deficiency in ADAMTS13, which leads to sheared red blood cells, schistocytes, and trapped platelets. TTP demands emergent plasma exchange, which drops the mortality from a terrifying 90% down to manageable levels. Finally, HUS. This usually follows bloody diarrhea from Shiga toxin-producing organisms like E. coli 0157H7, and here is a critical test day rule: do not give antibiotics or antimotility agents during that prodromal diarrhea. You will actively increase the risk of them developing HUS. Just don't do it.
Moving to Section 2, DIC and consumptive coagulopathies, systemic activation.
In acute DIC, the coagulation cascade is systemically activated. We're talking triggers like severe sepsis, trauma, or massive obstetric complications. Because the body's forming microclots everywhere all at once, it completely consumes all your platelets and coagulation factors. The lab picture is super distinct. You're going to see low platelets, prolonged PT and PTT, low fibrinogen, because again, it's all being used up, and high D-dimer from clot breakdown. You'll also see schistocytes on the smear, because those red blood cells are shearing right across these systemic microclots.
Section 3, coagulation and factor defects. Normal platelets, abnormal PT or PTT.
Let's trace the timeline of infantile vitamin K deficiency. Newborns are at immense risk. Why? Well, they're born with low vitamin K stores. They have a sterile gut that can't produce it yet, and breast milk is honestly a pretty poor source. If they don't receive that routine intramuscular vitamin K at birth, they'll classically present on days 2 to 7 of life with umbilical or GI bleeding. Since vitamin K is required for factors 2, 7, 9, and 10, the PT elevates first. If it gets severe, the PTT will go up too, which can lead to devastating late-onset intracranial hemorrhage.
But hey, this isn't just a pediatric issue. In adults, keep a very close eye on hospitalized or postoperative patients.
Say you have an acutely ill patient with poor dietary intake who gets put on broad-spectrum antibiotics for 7 to 10 days. Those antibiotics just wipe out their gut flora, and since that flora produces vitamin K, they deplete their stores and suddenly start bleeding from IV sites. You'll see an elevated PT and PTT, but completely normal platelet counts.
For inherited factor deficiencies, think hemophilia A, which is a factor 8 deficiency, or hemophilia B, which is factor 9. The classic presentation is deep tissue bleeding. Compared to a totally healthy joint, recurrent hemostasis, or bleeding into the joint, causes iron deposition and synovial inflammation. This leads to chronic joint space narrowing and articular surface erosions. These patients will show a prolonged PTT with a normal PT and platelet count, and they absolutely require strict factor replacement therapy to stop this irreversible joint destruction.
All right, Section 4 flips the script completely. Thrombophilia and HIT, the clotting pathway.
When a vignette presents an unprovoked blood clot, especially in a young patient, you've got to consider hereditary thrombophilias. Factor V Leiden is the most common one, particularly in white populations, and its mechanism is activated protein C resistance. The second most common is the prothrombin mutation, which simply means elevated prothrombin levels. And don't forget to watch for antithrombin deficiency. That one could be inherited, or it can be acquired through conditions like nephrotic syndrome, where antithrombin is actually lost in the urine.
Speaking of acquired hypercoagulable states, we absolutely must talk about heparin-induced thrombocytopenia, or HIT. Timing here is literally everything. Look for a massive platelet fall, specifically over 50%, happening right between days 5 to 10 after heparin exposure. Now here's the massive catch. Even though platelets are dropping, this is fundamentally a prothrombotic disease. The antibodies activate the platelets, causing dangerous arterial or venous thrombosis, or even necrotic skin lesions right at the injection site. The management? Stop all heparin products immediately. Avoid them for life, and start a non-heparin anticoagulant like argatroban or fondaparinux.
Finally, Section 5, hemorrhage management, emergency resuscitation.
So your trauma patient is bleeding on the floor. When emergency fluid resuscitation is needed for massive hemorrhage, the absolute first priority is to control the bleeding site early. Crucially, limit crystalloids like normal saline. Pumping a bleeding patient full of saline just dilutes whatever remaining coagulation factors and hemoglobin they have, making the coagulopathy so much worse. Instead, switch to blood products and trigger the massive transfusion protocol. This uses a 1:1:1 ratio of fresh frozen plasma, packed red blood cells, and platelets. It mimics whole blood and minimizes the risk of worsening the bleeding. But you have to be vigilant once that blood is hanging. Watch the clock for transfusion reactions. If the patient crashes with hypotension and wheezing in seconds to minutes, think IgA anaphylaxis. If they develop fever, flank pain, and hemoglobinuria within an hour, that's an acute hemolytic ABO reaction. Fever and chills alone in 1 to 6 hours is a febrile non-hemolytic reaction, and sudden respiratory distress within 6 hours strongly points to TRALE.
All right, this explainer gave you your algorithmic anchors. Let's recap them rapidly. Mucosal bleeding, platelets. Deep joints, coagulation factors. Prolonged PTT that doesn't correct, inhibitor. Platelets crash after 5 days, HAT. Anaphylaxis during transfusion, anti-IgA. So the real question is, when test A throws a multi-system curveball that completely blurs the lines between bleeding and clotting, will you instinctively trust the platelets or the cascade? Good luck on your exams,